Hi, this is Travis, and this is a presentation on the myths and truths in healthcare ventilation. This is going to be presented at the Winter ASHRAE Conference 2025. The session is called ASHRAE IAQ Mythbusters, Debunking Misconceptions about ASHRAE Policy and Standards. And then the specific presentation that I'm doing is called Demystifying ASHRAE 170. So we'll see if we can demystify ASHRAE 170 here. We'll jump right in to these myths. Myth number one, ASHRAE 170's ventilation requirements are based on evidence related to disease transmission, infection control, and hospital air quality. If you followed the ASHRAE journal over the last 30 years, you've likely seen healthcare ventilation articles a few times a year. They often start with a self-righteous paragraph throwing around claims about ventilation preventing disease transmission and controlling infections and ensuring safety. If you compiled all these introductions, about 100 articles, you'd have a body of work that would lead you to believe that healthcare ventilation standards were meticulously crafted to achieve these outcomes. For instance, you might assume that when we require 4 air changes per hour in the medication room there, well, that's because we have evaluated 3 air changes and 4 air changes and 5 air changes and 6 air changes to determine that 4 air changes is, in fact, the ideal rate. By the way, the image on the screen looks a lot like ASHRAE 170, but it's not. That's from the 1994 version of the air change table, which was published by FGI. ASHRAE didn't start publishing this table until 2008. Barack Obama was president when the first ASHRAE version came out. But to address the myth, no, these healthcare ventilation rates are consensus-based. They're determined by vote. And most of the key values were established quite a while ago, many decades ago, a lot of them before I was born. The single most common ventilation rate in ASHRAE 170 is 2 air changes per hour of outside air ventilation. That applies to 95% of the spaces in there. I spent years tracing its origin and finding it in the 1870s architectural literature. So back then, 2 air changes per hour was a natural ventilation standard for Victorian-era hospitals. So for 150 years, this number has literally just been repeated over and over and over without a rationale. You can go all the way back through 150 years of literature, and you will not find a single author since the Victorian era who positively justifies 2 air changes per hour. Like 2 air changes per hour is the right number, and here's why. Like nobody's said that since before Sherlock Holmes. The other rates like 4 air changes per hour and 6 air changes per hour and 10 air changes per hour usually come from the 1950s and the 1960s, and we've been repeating them ever since that era. Now, ASHRAE took this on. ASHRAE research addressed this in 2019, reviewing the scientific basis behind the standards. I would encourage you to very much read this report. And while it's diplomatically phrased, the report concludes that over 73% of our requirements have no rational engineering or clinical basis behind them. There is, by the way, some research. We do have studies on operating rooms and patient rooms, but it's not a lot. It's inconclusive, and it doesn't definitively point towards the code book numbers. So the best way I think to say this is that the specificity of our healthcare ventilation tables far exceeds the strength of the supporting evidence. If you were to audit any specific number within those tables, you would find only disappointment. Which, by the way, you can find that disappointment by reading this. I think it's Appendix 2, and you can look it up. You can go, hell, the imaging room requires 6 air changes per hour. What is the available evidence behind that? Oh, nothing. Okay. What's the rational basis? Oh, nothing. What's the clinical basis? Oh, there's nothing. And so if you want to be disappointed in that way, then please, Appendix 2 of this report. Okay. Myth number 2, the air change rates specified in ASHRAE 170 are necessary for infection control. 10 years ago, this was a much more prevalent discussion. ASHRAE healthcare discussions often linked ventilation to reducing hospital-acquired infections, or HAIs. You would come to these meetings and you'd hear HVAC professionals talking about ventilation as a factor in these infections and in these infection rates. Now, the truth is we do have some limited evidence that ventilation affects the infection rate in operating rooms, specifically the surgical site infection rate. But as I just talked about, even that evidence is debatable. There's not a body of evidence that points with a preponderance of evidence that ventilation at 20 air changes per hour is relevant in surgical site infection rates, right? And of course, more importantly, most of the healthcare ventilation requirements, 99% of the healthcare ventilation requirements, are not in operating rooms. They're in all the other rooms. So in order for this myth to be true, ventilation would need to clearly influence infection rates in general areas, patient rooms, exam rooms, treatment rooms, etc. But it doesn't. Most of those HAIs are from direct contract, and they're totally unrelated to air quality. So consider catheter-associated urinary tract infections and central line-associated bloodstream infections. Those are very common and prevalent HAIs, hospital-acquired infections. They result from contamination at the insertion sites, which are small and typically covered. So for ventilation to play a role, it would need to significantly affect the airborne contamination, and then that airborne contamination would need to deposit out of the air directly onto those sites right at the right time, which is just kind of a wildly unlikely scenario. That being said, within the 1990s and the 2000s, there were industry authors, even in the ASHRAE journal, who stated that up to 10% of hospital-acquired infections, quote, could be attributable to the airborne route. You can show that to your local infection control practitioner if you'd like to make them laugh. I don't actually hear this as much anymore, as much as I did 10 years ago. I think since that ASHRAE study came out in 2019, which is 5 years ago at this point, that this idea has mostly dried up in our vocabulary. Of course, in that study, if you go back and read the disappointment study, there is no evidence about general hospital-acquired infections and ventilation having any say in that. Okay. So in the last year or two, the chatter is more around infectious aerosols. And this is weird to say, but kind of important. Infectious aerosols like those from COVID-19 are not covered in the scope of ASHRAE 170. If that sounds odd to you, give me a second. I'm going to come back to it. But the first ASHRAE standard to incorporate infectious aerosol risk modeling in its development is ASHRAE 241, 2023, right? The folks on this panel were involved in developing 241, and we could probably tell you why. Infectious aerosol modeling requires consensus around assumptions and protocols and results interpretation. It's a pretty heavy undertaking, and that was just never done in any of the healthcare ventilation committees in, the 70s or the 80s or the 90s, right? So what do I mean when I say infectious aerosols are not in ASHRAE 170 scope? I know it sounds weird, but it's actually true. You go get a copy of ASHRAE 170 and you search for the phrase infectious aerosols. It's not there. ASHRAE 170 does include ventilation requirements for isolation rooms, like 12 air changes per hour and negative pressure, but those measures are cited to the CDC's tuberculosis guidelines, 1994, updated in 2005. So the healthcare ventilation group itself has no experience developing standards for infectious aerosols. And I mean, I'm sure you can find somebody to disagree with me on this, but I don't think anybody in the healthcare ventilation group would ever claim that that group has any experience with developing standards for infectious aerosols. It's just not something that's ever been done. Okay, so myth number 3, the ventilation rates in ASHRAE 170 are necessary to ensure optimal air quality. This myth actually has 2 versions. One says that we have higher ventilation rates due to higher contaminant generation loads, and the other version says that we have higher healthcare ventilation rates because healthcare spaces need to be markedly cleaner than commercial spaces, perhaps because there's, what do you call them, susceptible individuals present, right? And both of these are false. Neither one of them is true. Healthcare ventilation rates do not come from any analysis of contaminant generation. They don't come from any analysis of air quality targets. There's never been an adjustment of air quality targets for susceptible individuals. In fact, there's never been any numeric or quantitative analysis at all of the ventilation rates that we have in the standard. And furthermore, we've done the research. I was fortunate enough to be a part of this. There was a California Energy Commission funded study at an active hospital that tested ventilation rates from 2 air changes up to 12 air changes. We had air quality sensors at 72 locations in the hospital using multivariable air quality sensors. And the data showed there's no air quality improvement from 2 air changes per hour to 12 air changes per hour. You know, the air quality is the same. Higher rates like 4 air changes or 6 air changes or 10 air changes provide no air quality benefit. You're basically just spending energy, or wasting energy, I should say. Special little bonus myth here. If you look at this slide, the different colors in the slide are the different room types. So we varied the air in different room types, as it were. And the study found minimal air quality differences between rooms. Essentially, all the spaces in the hospital had numerically identical air quality, plus or minus a margin of measurement, right? And if you're familiar with healthcare ventilation, then you know that we have a bunch of positive and negative room pressure requirements, and those are there to prevent cross-contamination. Well, there's no cross-contamination in reality, right? They're all the same in terms of contamination levels. So myth number 4, this is the last myth. Myth number 4, the ventilation rates in ASHRAE 170 represent a balance between infection control and air quality and cost and energy efficiency. I mostly see this myth outside of ASHRAE. So with nurses or people that are involved in sustainability groups or things like that. It is tempting to believe that because healthcare ventilation comes from ASHRAE, and ASHRAE has energy efficiency way up top of its mission statement, that the healthcare ventilation standard would strike a responsible balance between energy and air quality outcomes, etc., right? And that is false. Nothing could be further from the truth. I've actually dealt with this one personally. In 2016, my organization signed on to a joint letter from the Healthcare Climate Council. So it was co-signed by 18 US healthcare systems with sustainability and energy goals. And the letter went to the ASHRAE 170 committee and asked the committee to evaluate and respond to questions about its energy consequences. The ASHRAE 170 committee got that letter and they did not respond, which is rude, but it definitely answered the question. So I've kind of kept at it over the years. Personally, I've submitted over 50 formal change proposals substantiated by energy concerns. They're always rejected, and the committee always, never say always, right? The committee always omits the energy discussion from the responses, and that's deliberate. The committee's position is that any consideration of energy is not within the scope of ASHRAE Standard 170, and therefore it's not something that they are at all supposed to comment on, right? So in 2021, myself and a co-conspirator of mine sent in a formal request, a proposal to the committee to add energy considerations to the scope, explicitly stating that healthcare ventilation has significant energy impacts and that there's an ongoing responsibility to evaluate those. The committee, of course, said, no, we don't want to do that. Quote, ASHRAE already has several standards that address energy limitations for healthcare facilities, i.e., this is not our problem, and we're not going to let it become our problem. So the bottom line is ASHRAE 170 has never considered its energy consequences, which are significant. And as of today, the committee has absolutely no plans or intentions of ever doing so. So does a minimum ventilation rate of 6 air changes per hour versus 2 affect energy use? Oh yeah, absolutely. Do the ventilation rates from 2 air changes per hour to 6 air changes per hour offer an air quality benefit? No, they absolutely do not. Is our committee working on plans to modernize the standard based on the state of the art? No, we are not. Okay, so those are the 4 myths. Hope you enjoyed the presentation. We'll move on from there.